Tag for the kind introduction, and I totally agree with you. I will be honest, when I have a case for atrial fibrillation ablation, I'm not worried because you know what you're going to face and you know kind of what you're going to do. But when I have like atrial tachycardia, I go to the cath lab. I'm not sure what's going to happen because sometimes it's as simple as you cannot induce the tachycardia, and you give all the medication that you can give, and at the end of the day, you fail to induce. And sometimes it's very insistent that you keep mapping and mapping, creating lots of maps to understand the mechanism of the tachycardia and where it's coming from. So it's not unusual when we have an atrial tachycardia that we have something interesting that we are looking at. So this is for atrial tachycardia. I have no disclosure for this lecture, and this is our hospital. I'm sure most of you are aware of it, at Qasimi Hospital in Sharjah in the UAE. And we have our EP cath lab, which is 24/7 cath lab, providing the service for different types of arrhythmia. And on average, we are doing for the atrial tachycardias, every month we are facing around 5 to 6 cases of atrial tachycardia. What I selected for you, some of the cases which I think they have some trick into it, that as we are doing mapping and understanding, we came to understand more and more the mechanism of such cases that I'm going to share with you right now.
Yeah, we are
so this case actually was yesterday. This case, I got a phone call consultation with the above ECG, as you can see, and this patient was in the ER, and they told me after the upper ECG and the patient blood pressure was hemodynamically stable, more or less was 110, and they decided to give verapamil. And after verapamil, it was a lower tracing that you can see. And they called me from the ER, from the other hospitals, and they told me that the patient reverted to sinus rhythm. And this is very tricky. This is one of the trickiest ECG, because when you look at the first ECG, everyone will say, okay, this is SVT at least. I'm not sure why they choose to start with verapamil, but when verapamil was given, they interpreted the second ECG as if the patient reverted to sinus rhythm. But on the other hand, when you look closer, you will see this is not sinus rhythm at all. Actually, the only thing that verapamil did, it slowed down the conduction. So instead of the conduction that you have in the upper channel, which was almost 2-to-1 conduction, it became 3-to-1 or 4-to-1 conduction. So it's only slowed down the rate. And guess what? After a few minutes, the patient came back to the first ECG again. So what verapamil did, just slowed the conduction, and the underlying rhythm, as you can see, very fast atrial rate. It's almost 280 or 270, the atrial rate. And when it comes to electrophysiology, as you all know, because I know that the second title, we have an eminent speaker, Dr. Anya Samir, and I enjoy so much her presentation on atrial flutter. She's so talented in making it so simple how to tackle the atrial flutter. But for us, at the end of the day, when we are in the cath lab, whether it's atrial flutter, atrial tachycardia, we are treating both of them the same. Whether it's if you have a macro reentrant atrial flutter or a macro reentrant tachycardia, the only difference might be the rate, but the mechanism, sometimes the strategy or technique of ablation, they are almost the same. So when you look with such rate, this is atrial flutter for this case, and this patient actually, she's inpatient in our hospital right now. It's always very interesting when you look at the tracing with a heart rate of 100 or 120, and you find the P wave, as you can see. I'm not sure if you can see the markers that I'm doing on the surface presentation, but whenever I found like a long PR interval, and everyone say, okay, this is sinus tachycardia with first degree heart block, I like to just give us, give myself a few minutes to make sure that this is not atrial tachycardia, because atrial tachycardia, sometimes it's very tricky, especially when you have a diagnosis of sinus tachycardia. You have to ask yourself twice, especially when you have a rate of 130, 120, you have to make sure that this is a genuine sinus tachycardia and not atrial tachycardia. This tracing is clearly because you have retrograde to atrial activities here. Maybe this will give you a clue that this is a form of atrial tachycardia. So now I'm asking you a question. Please look at the screen right now. I want you, when you look at this tracing, to tell me this tracing in figure A, this is re-entry or focal tachycardia. Just have a quick look without 3D mapping system, looking at this tachycardia. This is focal or re-entrant tachycardia? Compared to this one, this is another form of atrial tachycardia. This is focal or re-entrant. So for A,
which is proximal and which is distal CS?
excuse me?
Which is proximal and which is distal?
The activation here is proximal to distal. So the upper panel is proximal, the distal panel is distal. But I'm asking not where it's coming from, I'm asking about the mechanism, whether it's focal or re-entrant tachycardia. So actually, when you look at the A channel, I highlighted a column. I'm not sure it's clear, the highlighted part. This is the whole mapping of the atrium in one cycle. And as you can see, it's less than 50% of the cycle length. So this is focal tachycardia. Just when you have a quick look in this tracing, you will say, this is a focal tachycardia, this is not a re-entrant tachycardia. On the other hand, when you look at the B channel, when you look at the all the atrial signal mapping during inside the atrium, you will find that we have more than 80% of the cycle length during this mapping, and this is conventional non-3D mapping. So B is a re-entrant tachycardia. This is just going back to the basics of the conventional AP. Again, when you look at this tracing, and just before going deep into the two cases that I'm going to show you, we are reviewing with each other the basics of diagnosis of atrial tachycardia. Again, when you find a P wave coming just after the T wave was what seems as a long PR with such rate, we have to put on top of the diagnosis atrial tachycardia. When you look at the intracardiac tracing, this is the traditional entrainment that we used to do, and we still doing, of course, to differentiate between the different types of SVT. And when you look at this tracing, clearly, once we stop ventricular entrainment, you have the VAA pattern denoting that this is atrial tachycardia. Not only that, see when you have the atrial tachycardia running and we do retrograde ventricular pacing, and you can see the ventricle captured, but you have some sort of VA dissociation here, as you can see. This is another proof as well for the maneuvers that we can do inside the cath lab to prove that this tachycardia is atrial tachycardia without connection between the ventricle and the atria. So whenever we have a VA A during initiation or dissociation of the V from the A, or we have an AA drives the AHH, so we have to measure the AA and HH. If the AA is driving, this is also with atrial tachycardia, or we have variable VA conduction. This can guide us that this is an atrial tachycardia, because sometimes the diagnosis of atrial tachycardia is not that simple. Of course, location, it can come from anywhere. As when you look at this black points, this is sites potential for atrial tachycardia. Luckily, 70% in the right atrium, 30% in the left atrium. When you look at the crista terminalis, coronary sinus, and the tricuspid annulus, this accounts almost for 60% of the atrial tachycardia is coming from the right side. And 20% from the left side, they come from the pulmonary vein, especially if you have a patient who underwent procedure for AFib ablation, for example, and this patient has some sort of a gap, and this patient can come with left-sided atrial tachycardia or atrial flutter. Localization is very important in the surface ECG, because before going to the cath lab, you can know whether you will need to do a transeptal puncture or not. So simply looking at V1, if it's positive in V1, this can be a clue that you are facing a tachycardia coming from the left side. Of course, otherwise, if it's negative, clearly this might be coming from the right side or from the crista terminalis. This algorithm is very helpful. I do a quick look, especially in V1, looking at the P wave morphology, and we spend some time doing some analysis. And why, like having from the crista terminalis, we have this dumping negative P wave. When you look at the activation, the crista terminalis going from the left to the right in the upper channel, as you can see, you will find the activation sequence leads to this hump. Then you have an area of silence. Actually, this area of silence, it is a break of the tachycardia starting the next cycle. On the other hand, when you look at the down panel, when you have a flutter, you don't have area of silence because you have re-entry circuits going on. But on the other hand, you have this horizontal hump line, because this corresponds to the cavotricuspid isthmus, which carries very few muscle fibers. That's why you have this hump in cases of atrial flutter, CTI dependent flutter. Of course, different mechanisms can be happening depending on the underlying pathology in the atrium, whether if we have some sort of patchy fibrosis and scarring, or incisional if the patient underwent surgery, especially if congenital heart diseases, or if we have a gap in the incision itself, as you can see, or a patient underwent the ablation and there is a gap in the ablation line. All of this can give us a clue during history taking of the patient what we are going to face, because if you found a double potential in a patient while you are mapping a tachycardia, that the patient didn't do any procedure before, or the patient didn't undergo surgery, it makes a huge difference if the patient underwent surgery before, because you can map the incision line and you can determine the gap that you might be facing. Mapping, I think now it's much easier than before because of the 3D mapping system, especially the high definition, like with using the Pentaray, for example, that you can acquire so many points, creating very impressive maps so we can understand the mechanism and where is the tachycardia coming from. But still, entrainment is very crucial during verification, because sometimes you get two morphologies of tachycardia or two cycle lenses, and you want to know whether you are included in the cycle or you're not included in the cycle. So post-pacing interval and entrainment still is a very crucial step when it comes to atrial tachycardia and atrial mapping, especially in very difficult cases, and again, especially in left atrial tachycardias, which becomes very challenging. So this is one of the cases which was very interesting. We did 1 year ago. He's a 25-year-old gentleman. He complaining of palpitation on and off. He's dyspneic on exertion, and in his history, he gets dizzy attacks and near syncope attacks. And to be honest, we didn't know why the near syncope attacks. The tachycardia that were noticed, okay, it was fast, but this patient, he's a 25-year-old. So the ejection fraction 45%, because the patient, we saw lots of attacks of tachycardias in his history. We anticipated this might be tachycardia-induced cardiomyopathy because of the persistent tachycardia that the patient had. When the patient came initially to the cath lab, as you can see, this was the tracing. We have activation proximal to distal, and the cycle length was 260, around 260 millisecond. And this tachycardia, we anticipated this might be a typical flutter. Why not just to map it and verify it? Because when we did a post-pacing interval in the right atrium, we had a satisfactory less than 30 millisecond post-entrainment. So we said, okay, let's do a mapping for this patient and see how it's going on. But actually during mapping, the tachycardia stopped, and we paced again to induce the tachycardia. As you can see, the first 3 beats, we were pacing, trying to induce the tachycardia, and we induced this tachycardia again, proximal to distal, but the cycle length here changed. It became almost 300 millisecond, but we have the same sequence of activation, as you can see, proximal to distal activation. So we said, okay, we will carry on. We will start a new map with such cycle lengths, and we created this very nice re-entry. You can see a counterclockwise flutter, which is very neat, very nice map, showing the mechanism of the underlying tachycardia for this patient. Here, another view while using the Cart2Uni view. And we ablated this flutter with a very nice flutter line. And once we ablated this flutter, the tachycardia still there, as you can see, but the cycle length went back to 260. So the tachycardia switched again proximal to distal, but here the cycle length, instead of 300, it came back to the first tachycardia that we had earlier, 260 millisecond. So we said, okay, this might be a gap in the flutter line, but the cycle length being as such made us think, okay, maybe this is something else. Why not to remap it again? And once we have the Pentaray, we can create the map, as you all know, like in less than 5 minutes. So we did remapping for this patient of the tachycardia, and guess what we found? We found focal tachycardia, not the flutter anymore. We found focal tachycardia on the posterior wall, not far from the cresta terminalis. And I will mind you, when I go back to the flutter map, I want you to look at this column bar of the Cart2 map. It's the earliest was minus 124 millisecond up to 124 millisecond, which means we have here more than 90% of the cycle length of the flutter that we ablated. But when you look at the next map that we had here, we had minus 130 millisecond to 43 millisecond, which means we have less than 50% of the cycle length. And clearly, when you look at the 3D mapping system, it's a focal atrial tachycardia. And when you look at the window of interest, we have a very nice early potential in the mapping catheter of minus 130. And at the same time, we have a QS pattern, which is very nice in the unipolar signal on the ablation catheter. And once we ablated here, the tachycardia terminated, but I will show you the termination because it was not only very impressive, we had a very nice pause, as you can see in the window of interest. I will show it to you much more clearer here. We had a pause of 2 seconds post-ablation for this patient. This pause was, as you can see, it was significant pause, and it started, we put a catheter in the RV, as you can see here, and started pacing the RV. And this pause might explain the syncope in this patient, because this patient explains, I have attacks of tachycardia, and in between the attacks of tachycardia, I get some dizzy attacks and pauses. So our anticipation, because of this patient most probably had such attacks of tachycardia for quite some time, this patient became dependent on the tachycardia and had some sort of sick sinus. So this patient, when the tachycardia terminates, whether the flutter or the atrial tachycardia coming from the posterior wall of the right atrium, he gets attacks of pauses that might explain syncope. And this patient was kept on a backup pacemaker for 2 days because of the persistent bradycardia that this patient had. So after this, we tried to induce the tachycardia, as you can see in the upper panel, with burst pacing. We didn't induce any more tachycardias beside the 2 that I showed you in those patients. So this is one of the cases that we faced 2 types of tachycardia with 2 different mechanisms, the flutter, CTI flutter, and the focal atrial tachycardia. So we have a re-entry and focal atrial tachycardia in the right atrium in the same patient. The second case, this is a 60-year-old gentleman.
Can we discuss the first case, يا محمد لو سمحت دكتور محمد؟
As you want to discuss case by case, no problem.
Yes, please. عشان ما ننساش بس.
Sure.
We'll open this case for discussion. We have دكتورة دعاء فؤاد معانا. We have also Dr. Amy Boni. We have Dr. Rania Samir. Anyone has questions to Dr. Mohamed Magdy? طيب محمد.
دكتور محمد sorry دكتورة ميرفت اتفضلي يا فندم.
طيب. You said that you started by entrainment and the PPI was less than 30 milliseconds, and you were sure that you were on the right side. The circuit is on the right side, صح?
Yes. Sure. Yes.
So why didn't you start to ablate in the cavo-tricuspid isthmus? Because you were sure this is flutter. This is
exactly, Dr. Mervis. As we were mapping, because I was using the pentarray, and I was creating the map. While I was creating the map, the tachycardia stopped.
Okay.
And when the tachycardia stopped, the first one, the 260 millisecond, we induced another tachycardia, which is the 300 millisecond. So we changed the window of interest and we mapped it, and we ablated the flutter as exactly you mentioned. Here is the flutter. We did the ablation line. You can see this is the flutter line, Dr. Merva, that we ablated. Okay. And while we ablated this flutter line, we had the tachycardia of 260 coming. And instead of 300, we had the 260. So we thought about it. If this is the flutter is not ablated yet, or this might be another form of tachycardia. So we created another map, this map, and we found this is focal and it's completely different. I am sure you agree with me when you compare this carto map with the other re-entry map that I showed you earlier. So this patient, he had 2 cycle lengths, flutter at 300 millisecond, and atrial tachycardia at 260 millisecond coming from the posterior wall.
Okay. We have a question from Khalid Gamal. Let me read the question for you. How can you change the window of interest when the cycle length changes?
The window of interest, simply we do a remap and we just take 90% of the cycle length. This is the easiest way of doing it. Another way we can do it by editing. You can edit point by point, but sometimes this is time consuming, especially if using something like the Pentarray, you will acquire 1,000 points. So it will be very difficult. So it's better to create a remap. And with the remap, you can just edit the window of interest according to the cycle length.
Okay, we have another question, Dr. Mohamed Magdy from Budaga Gaguguli. How can I identify atypical atrial flutter? How can I differentiate between atypical atrial flutter and atrial tachycardia? How can you differentiate between atypical atrial flutter and atrial tachycardia?
You mean atypical atrial tachycardia?
Atypical atrial flutter and atrial tachycardia.
When we are comparing typical atrial flutter, whether clockwise or counter?
Atypical, مش typical.
Atypical atrial flutter, right? This is a question, okay. So
yes.
First, we see the morphology in the coronary sinus and the sequence of activation, where it's coming from. And then we start with entrainment. So one of the easiest way of doing it, you can take the coronary sinus, which is the base catheter, even before opening an ablation catheter, and start doing entrainment from the proximal coronary sinus, followed by the mid coronary sinus and the distal coronary sinus. Whenever we have the earliest, shortest post-pacing interval minus the cycle length, this means we are included in the circuit. If you have possibility of typicality on the right side, this is with more typical atrial flutter or atrial tachycardia. But the mechanism is very important, because sometimes it's very difficult if you are dealing with a focal atrial tachycardia, because if you're doing entrainment in re-entry, it will be much easier for identification. But for focal atrial tachycardia, sometimes it's very difficult, and you have to do more high definition mapping to identify the atypical form of atrial tachycardia, especially if it's coming from the left side.
Yes. Okay. Dr. Ahmed Tag, you had the question to Dr. Mohamed Magdy.
Yeah, actually, it's a very interesting case and a very interesting atrial tachycardia ablation. I mean, whether it's atrial flutter or atrial tachycardia. Do you think, I know that you said already that it's two types of tachycardia, but why not it's just one type? And when you did ablation, there is some deficient areas which hasn't been blocked, so there is some sort of connections. Is it just the cycle length or the mode of tachycardia? This is reentrant, because we know that atrial flutter is a macro reentrant tachycardia, while atrial tachycardia is micro reentrant. Do you think it's part of atrial flutter, the initiative of atrial flutter, or just coincident to tachycardias?
I think because, as I told you, once we ablated, that cycle length changed. And when we did remapping, Dr. Tag, it's a very good question. When we did remapping, the mechanism also changed. It's not the same mechanism. What we noticed in some of the cases, the second case that I'm going to show you, sometimes when you have like a focal rate, which is higher than the flutter rate, it acts as a driving factor. And of course, it's difficult because, you know, in the cath lab, when you have a tachycardia, you are focusing only on the tachycardia that you're having at that moment. But the question will be, what it will be if it was the opposite. Just imagine if we mapped first the atrial tachycardia and we ablated the atrial tachycardia, whether the flutter will be still there or not. Because the atrial tachycardia was faster than the flutter.
دي حاجات يعني ان شاء الله تبقى خفيفه، لو يعني طمنيني عليها بكره وقولي.
So I think they are interlinked, Dr. Tag, because the tachycardia didn't stop. The tachycardia just changed the cycle length. So they are interconnected, maybe like some sort of, you know, like you can think like they are connected together. One cycle, one circle is driving faster the other circle. When you cut one, the other one might stop, or the other one might continue, but at a slower rate, because this was the driving tachycardia. But I think they are two different mechanisms, because if we had a gap at the flutter line, the mechanism will not change. If we had a gap at the flutter line and we did remap, still we will have a flutter. through the cavotricuspid isthmus, but maybe the cycle length will be slower because of the previous ablation line. When you look at this map and you look on the other map that I'm showing you now, this is completely different mechanism. This is focal tachycardia. And once we ablated here, you saw we had a pause followed by sinus rhythm. So I think this is two different mechanisms in the same patient. Whether they are connected, I think they are connected. The flutter circuit connected with this focal tachycardia. And this is very nice observation that you noticed that the connection between the two tachycardias. I wish myself during this case that we had the focal tachycardia first, to ablate this focal tachycardia first, not the flutter, because at that moment it will be much more interesting.
Much, yeah.
Very much, Dr. Mohamed. Magdy, can we move to the second case, please?
Sure. So this is a 60-year-old gentleman. He came to our ER several times, having sometimes atrial fibrillation, sometimes he having atrial flutter, and we planned him for atrial fibrillation ablation and flutter ablation as well. I know, I'm not sure you saw the latest guidelines. I think we should discuss this a little because I was shocked in the guidelines when they mentioned flutter downgrading to class 2B in the guidelines in cases of AFib, because to be honest, I know it's the newest guidelines, but I'm not convinced. Still, if I have a patient coming to my ER with AFib and flutter, I will ablate the AFib and flutter. I will not leave the flutter. Although the guidelines now put it at 2B, that you could have a choice not to ablate the flutter, but still I'm not convinced. We can have this for discussion later on. To this patient, we took him to the cath lab and we had a CT scan, as you can see, on the posterior part, and you have the superior inferior vena cava and the right atrium on the front side. And once we started doing the map while we are inside the left atrium, we induced the tachycardia. And actually, it was a regular tachycardia. And we created this map, as you can see, while mapping the complete left atrium. And we found a very nice point. This point here, this yellow spot, I am circling it in circles now. It was a focal tachycardia coming from the right superior pulmonary vein, which was very early, minus 104 milliseconds. And guess what, Dr. Tag? We asked ourselves the same question. Whether this point was causing the flutter on the right side, driving the flutter, or this point is a point that initiating the left atrial tachycardia, whether it's typical or atypical. This was very interesting, especially after creating this map inside the left atrium. But what we did for this patient, Dr. Mervat, we did here entrainment and post-pacing for this yellow point again, just at the right pulmonary veins. And please notice the pentaray potential, this fractionation. You see this fractionation in the pentaray in the window of interest, very interesting fractionation as well. And when we did post-pacing interval minus the cycle length, it was exactly on the money, 250 millisecond, which was the cycle length of the tachycardia, as you can see. And I'm sure you agree with me, once you are inside the left atrium and the patient is in flutter and you have this sweet spot, let's call it sweet spot, with a perfect entrainment, we ablated in this point, and guess what? Patient had sinus rhythm. I want to tell you something which was very nice in this case. The activation sequence in the coronary sinus was proximal to distal in this patient. It was not coming from mid-coronary sinus or distal to proximal. It was proximal to distal activation. And look at the V1, the P wave morphology. This was one of the guiding factor. It was positive in V1. So having positivity of P wave in V1 and having this post-pacing interval with gap, as you can see, my ablation point around PVI isolation, it's related to the pulmonary vein. Once we ablated, we could achieve sinus rhythm in this patient, converting his flutter to sinus rhythm or atrial tachycardia to sinus rhythm. This is a focal atrial tachycardia. Another question, whether this was his flutter, that we assumed it's a flutter, or this drove the flutter on the right side, or maybe this was the drive for the atrial fibrillation. You never know, because when we are doing the procedure, as you can see in this case, I isolated the pulmonary veins, I ablated the focus, and here down here, I ablated the flutter as well. I did a CTI for this patient. So this patient, we ablated three things. We did the cavotricuspid isthmus, we ablated the focal tachycardia, and we isolated the pulmonary vein. Which is causing which? This is very difficult. And again, we asked ourselves in the cath lab, what about if we ablated the CTI first? Whether this make any difference if we ablated it last? What if we just isolated the pulmonary veins? I think if we didn't do this map and we just created anatomical map and we isolated the pulmonary veins, we will never catch this sweet spots that I told you that we ablated around the pulmonary vein. So the mechanism, you have different possible scenarios, but at the end of the day, the patient in sinus, and he's maintained in sinus, alhamdulillah, and he's doing great. But again, you will never know whether this was a figure of 8 taking from the left atrium, encircling the right atrium, this causing the atrial fibrillation or not. Actually, I have a case that we did last week. Hopefully in the future, I will share with you, because this patient, he's a young gentleman, he's a 35-year-old, and he comes to our ER every week with atrial fibrillation. So I decided to do, and this is one of the youngest patients that I did AFib ablation for him. And inside the cath lab, I did mapping and isolation for the pulmonary vein. And after isolation of the pulmonary vein, I do burst pacing. I induced again the AFib after isolation of the pulmonary vein. I did voltage map. I assure you, the ostia of the pulmonary vein completely isolated. So I took my pentarray and I did mapping of the very fast activated signals in the left atrium. And at the posterior wall, I found a rotor, which is a micro reentrant circuit inside the posterior wall. And guess what? When I ablated in this spot, the patient reverted into sinus rhythm. So this is very interesting, because this will change some of the concept that we have. This procedure for this patient was the first procedure. I isolated the pulmonary vein and the AFib was still running and going on. When we did high definition mapping of the high fractionated signal, we found a spot which showed a micro reentrant tachycardia in the posterior wall. Once we ablated this tachycardia, the patient reverted into sinus rhythm. So this is one of the theories of Michel Hessaguer in atrial fibrillation. That's why in some of his cases, he moved now to rotors mapping and rotors ablation using the cardiofocus jacket instead of only doing PVI isolation. This is things that's very interesting while we are doing the ablation procedure that can stimulate our mind regarding the mechanism. Here I'm illustrating the use of the pentarray, because this case was very nice conventionally and 3D mapping. On the carto map, as you can see, I have my pentarray. I hope you can see it clearly in this circle. And I'm just illustrating for you the use of the pentarray in such case, because it's very nice when you put your pentarray just right on the isthmus. So you can have part of the pentarray near the septum and the other part near the lateral wall, just after lateral to the ablation line. And you can appreciate from the intracardiac tracing that you have a very nice block in the isthmus just by looking at the pentarray signal very quick without doing even a 3D mapping system. You can see the difference between the septal poles of the pentarray and the lateral poles lateral to the ablation line. So looking at this spot can give you a clue that this isthmus is already blocked. So I hope you like the two cases. I tried to make the presentation for the cases and the refreshment for the mechanism as simple and quicker as possible. So I hope it's not a boring lecture, especially it's now 7 p.m. in Egypt. I'm sure you are you're starting your clinic or you're finishing your university. So I'm sure you're tired. I hope you enjoyed. And this second case is for open discussion.
Thank you, Dr. Mohamed Magdy. I'm Dr. Rania Samir for the interesting cases. I really enjoyed all the cases you presented as usual, and they are very complex cases and very sophisticated. I have just two comments about the two last cases, the one with the AFib and the atrial flutter, the one you isolated the CTI, and then you found a focal region anterior to the right pulmonary veins. I have only a comment. If you in this tachycardia, if you extended or you widened your circle of antral ablation in the right veins, I think you would have included this focus within. I noticed that your ablation, your circumferential ablation of the right pulmonary vein is a little bit closer to the ostia, but I think if you extended the your circumferential ablation to include more of the antrum, you might have included this focal region or this area which is close to the septum also. Do you agree with me?
I agree with you, and I mentioned that this point during isolation of the right pulmonary veins, you could have ablated while you were encircling the vein. But I want to let you notice something, Dr. Ananya. This point is very close to the transeptal puncture. It's not far from the transeptal puncture. So usually when you're isolating the right veins, it's not very common, especially at this spot, to be very much antral. Otherwise, you can lose your transeptal puncture. So in order to reach this point, you have to do certain technique and certain maneuver to tackle this exactly yellow spot. Otherwise, the transeptal puncture, you can lose it, and you will not have enough stability at this area. This area is one of the most, as you know, of course, this is one of the most difficult areas to stabilize. But again, usually in EP, you know, the difficult area is the most unstable area.
Yes, you're right. You're right. Well, as regards the second case, the one that you had a focus in the posterior wall and that you ablated the area of micro re-entry, I don't think it's not a focus. It was a micro re-entry circuit in the posterior wall after you isolated the pulmonary veins. Why didn't you think about isolating the posterior wall, the whole posterior wall, to make a box
first case or second case, Dr. Ananya?
The last case.
The last case. Say again the question. Sorry, I didn't get it.
Okay. You said that you had the patient with atrial fibrillation and you isolated the pulmonary vein, and then the patient went into the atrial fibrillation, even that you made sure that you were properly isolated the pulmonary veins, and you found a micro re-entrant area or a rotor in the posterior wall.
This is not this is a third case, Dr. Aranya. We're talking about the third case. Yeah. Okay.
Why didn't you think about isolating the whole posterior wall?
Two things. First of all, he's a 33-year-old. This is the first procedure that we are doing for him. And third, and most importantly, the patient cardioverted to sinus with ablation at that time and was not inducible again. This patient did burst pacing at 200 milliseconds, and no atrial fibrillation, no atrial tachycardia, no atrial flutter for this patient. So if I achieved my target with my first procedure, with such ablation, we consider this is more than enough.
Yeah, I totally agree with you, and thank you so much for the elegant presentation and the very nice cases that you presented. As usual, Dr. Magdy, you're making my task very difficult, by the way.
No, I'm looking forward to it.
Dr. Magdy, thank you for this elegant presentation, and I have one question. Maybe not related to the case itself, but to your experience in atrial fibrillation. Well, I myself am not such expert of AF ablation. However, I have attended a recent talk about, or discussion actually, for the British Cardiovascular Society last year about the arrhythmia group of which is called the AA Arrhythmia Alliance in the UK, as I'm a member of them. They were discussing the role of RA in AF ablation. Sometimes when you have more than one tachycardia while you're ablating AF, you have to think about the role of right atrium. How many times did you think about ablating certain focus in right atrium when you were ablating AF? It's just questions general. So if Rania or any other colleagues, Dr. Amipani or Professor Mervat, could tell us. But I'd like to have your say first, if you don't mind.
It depends on the number of the procedure. Like if I'm doing a procedure for a patient with atrial fibrillation for the first time, I'm targeting the pulmonary veins first. So this is the first strategy. So if you have a patient who's coming with recurrence, we have to ask ourselves two important questions. When the recurrence happened, whether it was acute post-ablation or chronic after some time. Because if you did ablation for a patient and the patient had recurrence within 6 months to 1 year, this might be a problem in the ablation lines that we did. But if the patient came with like AFib after 3 years, 4 years, it might be a non-pulmonary vein potential, as you explained. So we start stepwise approach. We will again verify the ablation that we did for the pulmonary veins. So we have to verify the pulmonary veins, that the pulmonary veins isolated. And if we found them isolated, we look elsewhere. So we look in the right side, in the superior vena cava and the inferior vena cava. We look for fast, as the cases that I just explained to you that we did for rotors that can drive the atrial fibrillation. But we never search for a non-pulmonary venous source during the first procedure, unless we have something so clear like the patient that I just explained to you. This patient was very interesting, and this is one of the youngest cases that we did. Today I had one of the consultation, and it's good that we are sharing experience with the whole team today, because this lady, she gets very frequent attacks of atrial fibrillation, and this lady, she has frequent attacks of atrial extrasystole, and the problem that this lady is 17-year-old. So this is quite a record. Echo normal, thyroid normal, labs normal. She's not controlled by all types of medication, whether beta blockers, class 1C antiarrhythmic medication. She's not controlled. Very frequent attacks of atrial fibrillation and atrial extrasystole. Maybe the atrial extrasystole causing the atrial fibrillation, but I think sooner or later, this lady, I'm not saying AFib ablation, she will need some sort of EP study so we can understand what's happening for this patient. I believe Dr. Nasir Marouche in United States in Salt Lake, he addressed the problem of using the MRI imaging to evaluate the percentage and the amount of scarring inside the left atrium. And he noticed that sometimes when you have a patient with atrial fibrillation for 1 year, he has more scar than a patient with atrial fibrillation for 5 or 6 years. So maybe it's a genetic encounter, maybe genetic predisposition as well. The case that I just showed you in front of you, when we did ablation for this gentleman, and this gentleman, he feels much more better now. It's almost 3 months since we did his ablation. He brought his wife. She had atrial fibrillation, and his wife is his cousin, by the way. So they're actually cousins. And guess what, Dr. Tag as well, and Dr. Rania, Dr. Mervat, their 3 kids, they have atrial fibrillation. Oh. So the husband, wife, and 3 kids, they have atrial fibrillation. So for sure, this is genetic predisposition. When you have a family with the husband and wife, they are already related, and the whole family, they have atrial fibrillation. So this is very interesting, and I think this is the beauty of EP, that it's more than ablation. You have to think more about the mechanism, what's happening, and how to treat it. So
okay, can I ask one question?
Yeah.
Sure.
Hello.
Yes, Dr. Amy?
Do you understand me?
Yeah, I can hear you.
Okay. So regarding the first case, I have 2 questions and comments. I would like to know in your practice how frequent you have such long pause after termination of tachycardia. And in this case, where you, if I remember, you say that you put a temporary stimulation of this patient. My question is to know if in this case you will looking for a sinus node dysfunction or not in this patient. Do you perform EP study to rule out sinus dysfunction or not? And the second comment is that if we assume that is two mechanisms of arrhythmia, how do you explain the clinical termination of two different mechanisms in the same time, following by long pause in these patients, which is responsible of syncope? Is it really a two mechanisms as mentioned Dr. Ahmed Tagadian, or just one mechanism but with the prolong of cycle length because of a more incomplete ablation of the first procedure? But the main point is to rule out the conduction disturbance in this patient too, because maybe in the follow-up we will observe the avert bradycardia sinus node dysfunction in such case.
Thank you for an excellent question. And whenever I have a case of atrial tachycardia and the patient comes to the cath lab in tachycardia, and this patient is young, and especially when it starts to be myopathic, as I told you, the ejection fraction was 45%. For me, this means that this tachycardia has been running for quite some time, maybe years. And the patient has the symptoms for the last 2 years as well. So those patients routinely, especially those patients, I put RV catheter from the beginning. So I put this patient back up because patient coming with incisive flutter, even elderly, once you ablate, you will have a pause. But the pause duration will be variable. Usually, it's less than 1 second. Here, it's more than 2 seconds, almost 2 seconds, as you can see. Why it's something like this happened and the patient kept paced for a couple of days? Because the SA node was not functioning for quite some time, and what took the upper hand, either the flutter or the atrial tachycardia, or both of them. When I saw this pause, I anticipated that maybe with the medication that was given to him, because he was receiving lots of types of medication before referred to us, some of the medication might put this tachycardia at slower rate or even termination. So whenever he had this termination, he developed such intermittent pauses causing the dizzy attacks and syncope. This is our assumptions. Of course, we have nothing 100% to prove, but we are looking backwards from the data that we have in front of our hand.
Thank you, Magdy.
This patient, we did EP study for him, answering this second part of your question. But actually, we didn't do it on the same day, because on the same day, we give isoprenaline, we give atropine, we give lots of medication. So yes, actually, the study will be not conclusive. And at the same time, we wanted to give some time for the SA node to recover. So after 48 hours, we got him back to the cath lab, and he was still paced, by the way, because he was bradycardic. And we did the sinus node recovery time, and actually it was severely diseased. And on day 3, I implanted a dual chamber pacemaker for this patient because his heart rate was severely low. It was sinus, but very low, and the sinus node recovery time was miserable. I think this tachycardia was for quite some time. But what's good, this patient, after 6 months, ejection fraction became 50%. So it started to pick up again. So the mechanism of tachycardia-induced cardiomyopathy, I don't think it's a questionable anymore. The mechanism of the cardiomyopathy for this patient was tachycardia-induced cardiomyopathy, and it's as well affected the sinus node, and the syncope might be due to the bradycardia in between, or the pauses that happened for this patient in between. Regarding the mechanism from the activation map that we created, I don't have any doubt that we had 2 mechanisms, but again, we will never know which one will be the driving factor, except you will agree with me, which one will be the driving? The faster or the slower? The faster, right? So I think the faster one was the focal atrial tachycardia. It was driving the flutter. So when we ablated the flutter, the atrial tachycardia cycle length changed from 300 to 260 milliseconds, because the flutter was already ablated that was running in the CTI, and the only focus that was driving was remaining in the posterior wall. Once we ablated, it unmasked the SE node, which was severely diseased, and this is what we had.